אוקיי, אני אשאל אם כל מי שבחדר מדבר עברית? Other people here don't speak Hebrew? Was this a yes, that you don't speak Hebrew? כולם מדברים עברית? מעולה, אז אני מדבר בעברית, אם יש בינתיים. אם מישהו ייכנס או ייכנסו שלא ידברו עברית, אז נשנה. אז ברוכים הבאים למושב השני של הכנס הראשון, המושב השני של הכנס הראשון של המרכז האוניברסיטאי לחקר המגפות. והמושב הזה הוא, כמו שאתם יודעות ויודעים, עוסק בהיבטים החברתיים של מחלת COVID-19. שמי אייל גרוס, הפקולטה למשפטים, ואני גם חבר במרכז, ואנחנו, הדוברת הראשונה שלנו, כרמית כץ, משקפת את נושא הכנס ובבידוד, אז היא לא תהיה כאן, אז יש לנו בעצם פחות דובר אחד. יש לנו 4 דוברים ודוברות, כולל אני בעצמי, גם יו"ר וגם דובר. דוברת אחת היא בהקלטה, אנחנו נראה אותה בהקלטה, ואנחנו, כל אחד מהדוברים או הדוברות, יש להם 20 דקות, ואנחנו נעשה את השאלות אחרי זה. במקרה הזה אנחנו לא צריך לבקש מהם לקצר בשביל השאלות, בגלל שהתבטא לנו דוברת אחת, אז אנחנו נעשה את השאלות בסוף כדי שיהיה חלוקה הוגנת של הזמן בין כולם. אז אם יש לכם שאלות או הערות לאחד או אחת הדוברים או הדוברות, תרשמו לכם כדי לשאול בסוף. אז אני מזמין את הדובר הראשון, אייזק ססון או איציק ססון, מחלקת סוציולוגיה ואנתרופולוגיה, שידבר על אתגרים דמוגרפיים ותובנות על מוות מ-COVID-19. הדוברים שכולם, מכיוון שכאן בחדר כולם מדברים עברית להבנתי, אז הדוברים שכולם אם רוצים לדבר בעברית או באנגלית. בבקשה.
לעמעם את האורות זה המתג הכי ימני בקרב.
ואני אתריע 3 דקות לפני הסוף, בסדר?
תודה. אז תודה רבה לכל מי שהגיע. Maybe I'll switch to English for the sake of the recording and people who may come in the middle. So I'm Issac Sasson from the Department of Sociology and Anthropology and the Herzog Institute on Aging. And I'm a demographer by training, and today I'll discuss a few demographic insights on the pandemic and specifically about mortality. And in the end, a lot of this would seem like it's epidemiology, but in the end I will try to tie it to social sciences and why it's important for, I think, for everyone in this room. I'll start with something that is probably very clear for everyone here already, is that age is perhaps one of the most fundamental demographic variables, and I think it's key in understanding this pandemic. Unfortunately, early on in the pandemic, accounts of the pandemic really ignored this variable, both by academics and in the media, and I think that failure to incorporate age really gives us a misunderstanding of how this pandemic evolved in different countries and different societies. And today I will very briefly show or discuss an international data set that my lab has been involved. It's a big project, so we're just part of it. It's run by the Max Planck Institute for Demographic Research in Germany by Tim Riff and Enrique Acosta, and by now there's over 70 scholars involved. In over 100 countries. We have in the data set over 100 countries. I will show it briefly. And we contributed a small part with the Israeli data. And I will show you I will talk a little bit about the project itself, but I will show a few results coming from this study. So again, like I said, age was really ignored in the beginning. And then as part of this project, my lab, we contacted the Ministry of Health very early on, when they still didn't publish the statistics by age, just raw data, raw counts that you can't really make sense of. And after some discussion, they agreed to make it available, not just to us, but to the entire research community. So of course, we were very happy about that. And then we were able to join this broader project that has been used in, by now, over 40 published papers have used this. There's more coming out every week. It's been adopted by international agencies, the World Health Organization, UNICEF, and so on. Like I said, this is probably an undercount because it keeps evolving every day. We have over 100 countries. We have cases, COVID cases and deaths, also vaccination data in many of those countries. In some of them, we even have subnational or regional data. So this is an evolving project. It's been published in the International Journal of Epidemiology discussing this data set, but I think this is the boring part. We want to talk about the results. A few words about the challenges and advantages of this data set. It's freely available for everyone. Part of the difficulty was harmonizing a lot of the national statistics we got from over 100 countries. As you know, governments and countries don't seem to conform when we talk about statistics. So we really had to, it's all national statistics, so these are official, formal statistics, but we still had to harmonize the data. And in some cases, we got very detailed data, so really by specific single age groups. In other cases, these are very broad age intervals, so you can see here sort of the distribution or from some countries. In some cases, it was 5-year age groups or 10-year age groups. It was uneven age groups in some cases, including in Israel in the Ministry of Health. They suppress small cell sizes, so for age groups, younger age groups where there's very few cases, especially early on, they give us nothing or they suppress it on purpose for confidentiality reasons. And we had to deal with all this stuff, which was a big project in itself, but I won't get into the details. But the outcome is that it really gives us high resolution, both temporally and geographically. This is, for example, from Colombia, the subnational data. We really get a sense of how the pandemic evolved by age group in different parts of the country, and you can sort of see these outbreaks over time, and they don't seem to be exactly, sometimes we see differences between age groups and so on. So this is part of what we see in the study. I'd like to, like I said, there's been about 40 studies published based on these data. I had little involvement in many of them, so I can't take credit for all, but today I will show you 2 studies that I think are important. One of them is mine, so of course I would think that. But they really showcase how you could use this data and what kind of insights we can gain. So the first one is, I think by now it's a lesson that is well learned by most academics. But this is the insight that population age structure is really important for understanding the pandemic because it accounts for most of the differences between countries. So a lot of the narratives we heard early on and still do, why Italy did so poorly compared to South Korea, which was a success story and so on. A lot of these narratives that are interesting to read sometimes, it turns out that a lot of these differences could be explained and are explained indeed by just one variable, population age structure. And I actually was fortunate or unfortunate enough to spend half of the pandemic in Israel and half of it in Sweden. And I really saw two different policies, and you've all heard about the Swedish model and all these accounts. But in the end, the differences between Israel and Sweden weren't that great when you factor age. So before we get, maybe it's a bad message for social scientists because we like to come up with theories, but often the story is much simpler. I'll talk a little bit about that. The second example, which I'll give a bit more focus to, is what happens when we contextualize COVID mortality or the relationship between age and COVID mortality in relation to other aging-related causes of death. So just, again, very briefly about, you probably remember these figures, the case fatality rate, or how fatal was COVID early on. We got very different estimates from different countries, about just over 2% in Korea, up to 14 or 15% in Italy, and so on. And then this study, very interesting study by Christian Doodle and other colleagues from the Max Planck Institute, using our data, they really decomposed it, very simple decomposition, and they show that this is the case fatality rate, like I said, from 2% to 14% in Italy. They decompose it to the age component and the fatality component, and it turns out that in most countries, about 2/3 of the difference is explained purely by age. So just to maybe make us more humble when we theorize and try to come up with explanations why these countries, some of them are failures and some of them are success stories. Often it has nothing to do with our interventions. The second, and I think more interesting, but maybe more novel, is what happens when we contextualize the relationship between age and COVID mortality. And I think about this, thinking about it from this broader conceptual framework, how can we evaluate new health hazards when they emerge? As a demographer who specializes in mortality, one of the best ways we have is to see what it does to mortality, or how does it alter the age and mortality relationship, or the age mortality curve. We don't have many laws of nature in social science. One of the laws that does seem to hold is the Gompertz law of mortality. And it's a very simple law by Benjamin Gompertz from 1825. it basically states that the risk of mortality doubles every fixed number of years. So basically the relationship between mortality or log mortality and age is linear, or it's log linear, if you will. And then when a new health risk emerges, we can ask ourselves, how does this new health risk, in this case the COVID pandemic, how does it alter this fundamental curve? One option is that we can see here, this is a hypothetical scenario, that it just proportionally increases mortality for everyone. So if you're a 20-year-old or you're a 60-year-old or whatever, you experience a certain proportional increase in mortality. In real data, we know it's about 10%. I'll get to that later. In Israel, at least, in other countries, it varies. Another option is that really it changes the slope of this curve. So it really changes the fundamental relationship between age and mortality. Of course, there's many other options, but these are kind of like these stylized models. And what I tried to do in the study was already published last year, so you can look up the paper if you want. I tried to basically distinguish between these scenarios. In this case, again, the risk increases for everyone proportionally by the same factor, whereas here it's disproportionately affects some groups, some age groups. In this case, could be the older adults or younger people. It depends on the scenario. Just looking at the very simple data, this is a plot from the paper where I compare COVID mortality by age to the flu, the influenza and pneumonia. And we see there's two things we can learn from this figure. First of all is that COVID mortality does not, it's an order of magnitude higher than the flu. So all of these people who claimed it's just another flu, we clearly see that it's not. The gap here is about, it's 5 to 8 times higher mortality. This is early on the statistics, so it probably changed a bit by now, but we basically get the same results. The other thing we can see is that both of these diseases act quite similarly in terms of how they evolve with age. So both of them follow this linear relationship, log linear relationship with age, and we just see this proportional increase. But this is just one respiratory disease.